cute. Oh, that's adorable.
But yeah, thanks very much for giving us the opportunity to come here today and share this research that we completed recently. So just to say that we did this research alongside the Nuffield Trust, and it was funded by Marie Curie. For those who maybe are familiar with our team, we are the Health Economics Unit. We are part of the Midlands Lancashire Commissioning Support Unit. We're a team of health economists, data scientists, and econometricians, and we do basically economic modelling, analytics, pop health management type work across all different levels of the NHS, and also with external organisations, charities, and others as well. I am a health economist, but not long ago I was an analyst. So that's where, when I did a short stint in policy, and then I moved into analytics, and that's kind of where I started my career. But I got really interested in how services were funded and delivered and designed and all that. So then I decided to become a health economist. So yeah, I will pass to Gayathri just to introduce herself, and then we will get started.
Sure, thanks, Lisa. Hi, everyone. I'm Gayathri Kumar. I'm a health economist. I joined the HU last summer. Prior to that, I was at the Office of Health Economics and also in industry. And yeah, it was a really great piece of work, a really great opportunity to work on this with Lisa and the Nuffield Trust. Lisa did by far the majority of the work, but I'll talk a little bit about the sensitivity analysis that I did. And yeah, it was doing my daughter's hair before nursery today that made me smile. She's gone from liking low ponytails to bunches, and now high ponytails, which looks vaguely 1980s. I don't know if that's sort of around the same time period as the Doors, or as the Doors the 1970s. I don't know, but maybe maybe our daughters can have a little party together or something.
How lovely.
Thank you. So we'll get started. So going in from happy things to maybe not so happy things, because we're going to be talking a bit about end of life. But just by way of context and a bit of background. So each year around 650,000 adults die across the UK, and 1 in 6 of those die in poverty. Over the next 10 years, these numbers are expected to increase. And by 2035, it's predicted that the number of deaths in the population would be about 12 or 13% higher. To put that into context, it's about an additional 85,000 more people dying each, around 85,000 more deaths in the year in 10 years' time compared to today. When it comes to end of life care and support, we really only have one chance to get it right, because it's people are at their end of life. And we know that the quality of care that they receive is greatly influenced by the care and support they receive from publicly funded services. But despite that, there's actually very little evidence on how much public expenditure or how much is being spent on people in the last year of life. And this gap means that there's an absence of information to policymakers and decision makers about where to spend and allocate resources, I suppose, in the best way, so that people get the right support they need when they need it. And to address this gap, we were commissioned alongside the Nuffield Trust to come up with some estimates around end of life spend across healthcare, social care, and social security. Won't go into this slide in too much detail, because I'm going to go into it in a bit more detail in the other slides, but just to highlight that this was a very rapid analysis. We did it over 3 months, just before coming up to Christmas break. I think probably finished the bulk of it over Christmas, which was fun. We aimed to estimate end of life care in 2022. Data and evidence wasn't always available for that year, but we kind of used estimates from various studies or from earlier time periods, and we tried to kind of put it in 22 2022 activity or cost estimate levels. We're specifically looking at adults aged 18 or older. The analysis covers all 4 nations in the UK. I'll just present the findings relating to England today. And just to note some of the gaps and limitations, which I'll go into detail a bit in a moment, but that short time frame and also just an absence of data from the literature and even publicly available data on people at end of life made it quite difficult to do this piece of research. Just to note what we costed. So we estimated spend on GP practice activities, so contacts and prescribing, community care contacts, non-urgent emergency care, so this included ambulance and NHS 111 activity, in-hospital emergency care, so A&E visits and emergency admissions, out of hospital, that should say in-hospital non-emergency care, which included elective admissions and outpatient appointments, and also hospice care. For social care, we included local authority funded care, so that was residential and home care, and also other care spend areas like equipment, for example, and also continuing healthcare, which is funding that's provided to people with complex healthcare medical needs. And then across social security, we looked at various kind of welfare payments and benefits. So personal independence payments, attendance allowance, universal credit, carers allowance, housing benefit, and pensions. We purposefully looked beyond just care and benefits that people would really receive specifically at end of life. And the reason why we did that was because through previous research, Marie Curie highlighted just the significant number of people that are dying in poverty and the importance of financial security. So they were really keen for us to kind of take that more holistic view as well. What was out of scope? There were a few things that we had planned we wanted to analyse, but we couldn't because we just simply didn't have the data and evidence. But what was out of scope altogether was informal care costs and expenditure, and self-funding care as well. And the focus wasn't necessarily on effectiveness or quality of care, it was simply kind of a cost analysis. In terms of our approach, we undertook extensive stakeholder engagement and meeting with 50 different individuals from various organisations. So people working, for example, in social care, working with local authority data. We also met with academics as well, for example, who were doing research either in similar in healthcare or in estimating those social security benefits spend as well. We undertook an evidence review. So of the papers we identified, 34 were reviewed in detail. In addition to the evidence review, we collated additional data and evidence that was publicly available through survey data and published statistics as well. But we also got unpublished data through freedom of information requests and also direct from organisations. So Hospice UK, for example, and NHS Wales provided us with data that we were able to include in the analysis that's not publicly available. And then we analysed that data and built an assumptions-based model that incorporated sensitivity analysis. In terms of the methods that we used, there was no kind of nice, neat data set on on the activity level, for example, on healthcare and the costs associated with each activity. So we had to kind of draw on the various data and evidence sources that we had gathered, and kind of built up cost estimates in different ways across the three sectors. So for healthcare, we mainly, for the most part, we came up with an estimate of activity per person in the end, who in the last year of life, and we basically times that by unit costs, and then that allowed us to kind of get to a cost per person, which we times by the number of people who died. So that was kind of like a bit of a bottom-up approach. For social care, then we took a slightly different approach, just because even in the data and evidence that we were able to gather, there was kind of no reliable estimates specifically of social care activity at end of life, or in the last year of life, I should say. So what Theo did at Nuffield Trust was he used research that he had previously done, and he was able to come up with an estimate of the cost of services in the final year of life as a proportion of total expenditure. And then he applied that basically to current social care expenditure. And then the last sector, social security, we used data on welfare payments that was published on the Department for Work and Pensions data, and we accessed that through Stat Explorer. Some of the data was available specifically for end of life, but it wasn't always coded in that way. So we had to kind of come up with an estimate of the proportion of people who are dying each year within each age group, and then times that by the aggregate benefits across the 12-month period. So we kind of had to cut up lots of jigsaw pieces to size to make them fit together to come up with these estimates. So we know that it wasn't perfect. So to kind of like understand maybe the level of uncertainty in our analysis, we undertook some sensitivity analysis as well. So I'll pass to Gayathri now, who will talk through the sensitivity analysis.
Sure. Yeah, so we undertook a probabilistic sensitivity analysis and a deterministic, a series of one-way deterministic sensitivity analyses as well. With the probabilistic sensitivity analysis, given that our model had mostly cost and activity inputs, we applied a gamma distribution to all of those parameters except those that were unlikely to have a measurement error, such as the number of decedents, of people who died in 2022. Where possible, we derived standard errors from the data set or wherever it was reported, but that was in very few instances. So we took a more conservative assumption around the extent of uncertainty and assumed that the standard error was equivalent to the mean value. Following the assumption used in another end-of-life costing paper in oncology in Round et al. 2015. We undertook 10,000 simulations and derived the mean of those and 95% credible interval to estimate the extent of uncertainty. And then with the deterministic sensitivity analyses, we varied each of the inputs by plus or minus 10%, and then the 12 parameters with the greatest impact on the greatest deviation from the base case result were plotted on a tornado diagram. I'll just hand back to Lisa.
Thank you. That's kind of a bit of an overview of the methods. In terms of the challenges, I touched on them already. We didn't have a whole lot of time to do the analysis, because we were bringing together data and evidence from different sources. We were faced with like inconsistent definitions and time periods across the data sets, across the different activity elements that we were analysing. Social care sources were limited. When we were trying to estimate spend for each nation, really, we only really had kind of were able to kind of gather a comprehensive kind of enough information, I suppose, for England that allowed us to estimate each area. For Scotland and Wales, the data was a bit more patchy, but we were able to kind of come up with good enough estimates that were specific to the nation around hospital care, for example. But there were some other gaps elsewhere. And then Northern Ireland, there simply was no real data or evidence available. So what we did was we kind of used kind of mean aggregated estimates for the countries that we had, and then we applied it to the other countries where the data was missing. So just, I think, well, I'm only presenting the findings for England today, but when interpreting the results for Scotland, Wales and Northern Ireland, it's just really important to be aware of that. In terms of estimating costs, we used unit costs from taken mostly from the NHS National Cost Collections and also from the PSSRU. In other cases as well, in the minority cases, we took some costs. We were able to estimate some costs that were published in the literature. But when you're using kind of unit costs from the National Cost Collections, usually they're based on kind of the average patient. But we know that people end of life tend to be in hospital for longer. They've got more complex needs and all of that. So we did some we applied some assumptions and were able to kind of estimate potential unit costs at end of life. In some cases, for example, we were able to do that for emergency admissions. And I kind of mentioned this already, but some benefits data specific to people at end of life. We weren't able to specifically say whether they were at end of life, but we were able to kind of come up with proportions of people who died and then apply the benefits values over the population. I'd say no, it definitely in healthcare anyway, but no method for estimating activity and unit cost was the same. So there is a very large methods section in the report. I think it's about 32 pages long. If you're interested in that, you can go ahead and have a look. But I'll move on to the findings now. We will use Menti at this point. And I put the question up here as well, Rachel, in case it's easier. So the first question is, what was the total expenditure on end-of-life care in England in 2022?
I have shared my screen.
Thanks.
What a team. I know the answer, but I actually can't remember. I think it will when you're happy that we've got we're well represented. I can click it and it'll tell us the right answer. It's exciting, isn't it?
Very exciting.
All right, shall I show our audience the correct answer?
Yes, please do.
It is indeed
18 billion. If it's easier, Rachel, because I'm going to navigate between slides, I can put the Menti up as when we come to questions. Does that make sense?
Whatever you like is fine. I will just do as I'm told, Lisa. I've got them lined up, so I can just click to the next one if you
okay.
Just let me.
I stole the screen back. So yes, in 2022, public expenditure on healthcare, social care and social security was around 18 billion. In England, there were 540,000 deaths. So it equates to about £33,500 per person who died. The next question on Menti is, which sector do you think contributed most to more than half the cost?
Shall I reveal all?
Yes, do. Oops. The answer is healthcare. So over half was spent on healthcare, so £9.5 billion. 3.9 was spent on social care, and 4.6 was spent on social security payments. We have another question. So what was the largest driver of healthcare spend? No surprises here, I suppose. The answer is unplanned care in hospital. So I'll just go into the findings of hospital or healthcare spend in a bit more detail, and also show this lovely graph, which I think it brought me so much joy to make this. And as I was doing it, I wondered why I ever became a health economist when really all I like doing is making graphs. And I should have just stayed being an analyst. No, I'm joking. But if anyone wants to make this graph, I can actually share the code as well, Rachel, if that's helpful, and some dummy data. It might be useful to people if they're presenting where activity, for example, even across different services where they work. But you can see here that unplanned care in hospital, in particular unplanned admissions, accounted for over half of all healthcare spend. 80% actually of all care, 80% of all spend was in hospital settings, which is a significant proportion. Only 11% was spent across community and primary care, so community care activity and also the GP practice activity combined. That was only 11%, 4% on hospice care, and also 4% on ambulance care. So I suppose if we put that in another way, so for every £5 spent on healthcare, 4 was spent on hospital care. 50p was only spent on community care, and 40p was spent on hospice care. So yeah, this slide just presents kind of the relative spend at end of life relative to all of healthcare. So in primary care, it accounts for 2.1%, community prescribing and healthcare activity, both about 4.5%. End of people in the last year of life account for about 11% of ambulance and 101 activity, and about 10% of acute healthcare activity. So quite a sizable chunk. Just a quick note on hospice care. So the majority of hospice care, so over 65%, is provided by independent hospices. So actually government only, or public expenditure only, accounts for 44% of total hospice care. The next question on Menti is, what was the largest driver of social care spend? We'll move to social care now. Oh, we're getting mixed. Bit of variety in this one. We get another 10 seconds. We'll reveal the answer.
Less sure about this one, less clear.
Yeah.
Okay, shall I? Here we go. And it is?
Residential and nursing care. So the largest share, 62% almost, goes towards spend on residential and nursing care. This is only local authority funded care. So there's obviously a significant proportion as well of self-care funded activity that happens. The next biggest spend across both of these is the continuing healthcare, which accounts for about 24% of total social care spend activity. Social care spend on activity, and then the rest is on home care, and also that last one there around other, as I said, covers kind of equipment and stuff like that. The last Menti question relates to the social security question. So what is the largest driver of spend on social security payments? So the state pension is provided to people of pensionable age or older, and then the other three are working age benefits. Well, clue there. So I can give the answer, which is pensions, which is no surprise. So almost 90% of spend on people in the last year of life on social security spend is from the state pension. A small number of people get pension credit. So pension credit is kind of an additional payment that people, I'm going to say living in poverty, but that's not I think it's, I can't remember exactly the criteria for getting pension credit, but basically people who are less well off get this additional benefit. And these are all benefits that people receive at working age. So for example, the universal credit ill health, you will get this benefit if you're terminally ill. And yeah, so that's the main findings for social security. So just a bit of a reminder, just to highlight really kind of the scale and where the big spend areas are. So it's your emergency admissions, your pension and residential care. And then I suppose your last big one is your elective admissions as well. In terms of the sensitivity analysis, Gayathri, do you want to mention anything on this slide?
So the mean estimate was 17.8 billion, which is roughly in line with the deterministic base case estimate, with a credible interval of 17.7 to 18 billion. So at least when you're looking on the scale of billions, it's kind of a relatively tight credible interval around that mean estimate. And then with the deterministic analysis, you can see that the tornado diagram, there are like clusters of results, and that's essentially because the model is linear. Because as Lisa was saying, it's a cost times the activity, and then adding that up across the different sectors. So logically, the sort of the parameters with the greatest impact from the results were the ones that had the greatest, that contributed the most to the overall result anyway. Because by varying them by plus or minus 10%, you're taking 10%. The 10% figure is a lot larger for the bigger categories. So emergency admissions has the greatest impact, followed by residential and nursing home costs, and then elective admissions are planned care in hospitals. Yeah. Back to you, Lisa.
Thank you. And we're almost at the end. So just in terms of some key messages, just to recap, hospital spend continues to dominate the healthcare spend. I suppose it's no surprise, this is no surprise. I think what was the biggest surprise to us when we looked at the results at the end was just how big that difference was between spend in hospitals and spend in the community, especially because of the focus that there has been in the recent past, or of the past number of years, I suppose, around shifting activity out of hospitals into the community and all of that. But it just kind of demonstrates that there's still a lot of work to be done to be able to realise some of the potential cost savings and benefits to the system by shifting those resources out of hospitals and into the community. Secondly, there is insufficient focus from policymakers on people at end of life. And this may well have been partly due to the absence of routine data, and we hope that this research will kind of just highlight where funding is being spent and how it's being spent, and help decision makers to make more informed decisions. And then lastly, the key takeaway is that there's real need to improve data in this area, and we've made some recommendations around, for example, improving sector-specific data, particularly around community services and social care, improving the data as well across all 4 nations, in particular Scotland, Northern Ireland and Wales. In addition, we also made some recommendations around routine linkage of health, social care and security data to data on those who have died, to be able to better estimate actually how much spend is going towards people in end of life across each sector. We also made some recommendations around publishing kind of cost data specific to people at end of life for research purposes. And lastly, we also made recommendations which would, I suppose, follow on from improved data gap. From after improving data gaps and improving linkage, then we would hope that it would allow for more in-depth analysis of different groups to understand kind of where there are maybe inequities in access and variation across the population. And lastly, I suppose this research, it tells us how much money is being spent across health and social care. But what it doesn't tell us is whether people are getting what they need when they need it. It doesn't tell us if we're spending enough on people in the last year of life. And it doesn't really tell us if funds are being allocated in the best possible way, so that those who really need care and support are getting it as well. So yeah, I think that's it really. I think that's the last slide. If anyone has any questions, happy to do our best to answer them.
Thank you both. Thanks very much for going through your research and your findings. We've got some claps happening in the room. No, I really appreciate you coming to sort of share with us what you're asked to do and your approach to it, and obviously those the findings, and I think you've already said I haven't got any questions on Menti. If anyone's got any, because I didn't know where to put it. I didn't put it in the right place, you see, so I've confused my audience yet again. But I do have a hand up. Is that Simon? Simon, have you got your hand up?
Yeah, I was curious about how this
Sorry,
could reflect how does this compare internationally as well? Are we getting a good rate compared to other countries? Do you have any suggestions on that front?
I don't, I'm afraid. We didn't explore that in the short time frame that we had. But it's certainly something.
Interesting question. I mean, maybe next steps, maybe something sort of to follow on from this research. I have another question from Jonathan.
Hi, yeah, that's a really interesting piece of work. I was just reflecting on self-funding care, because I think there's sort of several 100,000 people in nursing care have got 100,000 a year. So I don't know, there's maybe 50 billion self-funding around close to end of life. So by proportion, this is, yeah, maybe only a third of our end of life. Maybe perhaps that's picked up by health and social care services themselves.
Yeah. So you say possibly £50,000 self-funding per year? No, 50 billion.
Nursing care is about 100,000 a year, and there's several 100,000 people living in nursing care. So there's probably, who knows, 30-40 billion spent on self-funding nursing care. People maybe live for about a year in nursing care. So sort of, back of a fag packet type estimate suggests it might be 30-40 billion spent on care that's not captured within this, I guess, maybe self-funded.
Which I suppose if you think about it, so those who are self-funded or those who receive publicly funded care, are those, it's based on financial
means tested.
Yeah, because if you've got any assets,
that's where it is.
If you have any assets, you have to self-fund. So there's not many people living in care are funded by local authorities at all.
If 1 in 6 die in poverty, then I suppose probably our numbers aren't too far off. Oh, okay.
Yeah. So
actually,
most of it's self-funded.
Our estimates have always tended to be on the kind of more conservative end, as when we were kind of estimating our activity and our costs, because we didn't want to overestimate. So if anything, I suppose we're probably presenting an underestimation of the real true number.
Yeah, I think you should want to be really clear. This is only a part of spend, and maybe the smaller overall part of spend by the state.
Yeah, because it's that I suppose it's that proportion. If you do have that whole picture, which you don't have, I guess it's very, very difficult to get to. But those same people who are self-funding in that context are being paid for in a sort of, for example, emergency hospital treatment. So it's sort of a. I got another question from Sarah. Hi, Sarah.
Hello. Hi. Thank you. Really, really interested. I just wondered if you knew what the total hospital spend was, and therefore how much proportionally was on end of life. Of hospital spend.
For acute care, it's about 10% based on this, comparing it to previous research that Nuffield Trust did. But I don't think we came up with that number for all of hospital care.
Right.
Yeah.
Yes, from there. But in terms of the total acute, sorry. So if you take the whole all of acute sector cost, how much of that proportion is end of life?
About 9.5%.
It is 9.5%. Oh, okay.
Yeah.
Okay.
Just for the acute care.
Just the acute. Yeah. Okay.
Elective care, like elective length of stay, is shorter in people at end of life. So maybe the proportion of elective care may be a smaller proportion. But we need to do a bit more of an analysis, I suppose, to really look at the different settings.
Yeah, brilliant. Okay, thank you. Thanks very much.
Thanks, Sarah. So there's a couple of questions on Menti. I don't know whether you can see them, Lisa.
Yeah, I can bring them up.
I can. Yeah, there we go.
That first one is a big question. So how could we optimize the system to spend the funds better to make more of an impact? I suppose we didn't necessarily answer that question in this research because we were simply only looking at kind of how much is being spent on and where.
Describing it.
Yeah. And then I suppose it depends on like what impact you're interested in. Are you improving patient experience, improving quality of care, shifting activity from hospital out to the community, improving discharge pathways? All of that stuff, I suppose, would need to be taken into account. And then I suppose it's system specific then as well, based on population need. So there's lots and lots of things you would really need to do to help improve how you're spending funds for people at end of life. Gayathri or anybody else, would they like to come in and add to the question? Or if not, no worries, carry on. Did we look into impacts of new legislation regarding euthanasia by any chance? We didn't for this piece of work, but Sarah Scobie at Nuffield Trust is doing some further work in this area and another project. So it kind of did come up in conversations as we were doing the work, but we didn't include it in our analysis or our research. The next question around shifting from reactive to proactive care could lead to having a longer end-of-life phase. This could indeed increase the end-of-life spend. I mean, it could in one way, but if people are at end of life and you have access to like good palliative care support, then and maybe you might be, I suppose, not just palliative care support, but maybe into access to like integrated care teams as well. They may be able to identify sooner when people are nearer towards end of life, or maybe if we're looking at the overall period across the last year of life, it might minimize emergency admissions and all of that type of stuff if people are having more proactive care, I suppose. Yeah, anybody would like to comment on that as well, please do.
I suppose maybe one other thing relating to that is that we didn't consider quality of life impact in our analysis, but shifting from reactive to proactive would certainly improve that, even if it does maybe slightly extend the end of life phase.
Yeah. Thanks, Gayathri. And then in terms of the aging population, increased number of deaths leading to increased spend. Sarah wrote a blog on the kind of data gaps and limitations, and 10 years ago there was a piece of work to try and estimate end of life care. So I think she kind of ends her blog hoping that in 10 years time that data gaps will be addressed and routine linkage will have been improved, and then we will hopefully be able to quantify it even more robustly, more precisely over time if data improves and all that. Locally though, if an ICS has access to linked healthcare data sets that's also linked to mortality, and even possibly social care data as well, you could do your own analysis locally to see where people at end of life or in the last year of life are, which services they're using and how much that's costing the system.
So we did actually do in the strategy unit, we did sort of a couple of years ago now, we did a piece on end of life, and it was about healthcare usage in the last 2 years of life, so it's a slightly longer period of time, and that was really interesting. I think I'll put a link on the web page, but we followed that up with, I just remember we had an Insight Festival at the time, and we followed that up with sort of with the exploring all sort of different avenues and so on. But it was very interesting, and that was using sort of basically who died in a particular period of time, and then mapping it backwards. What other health and social care services those people had used in those final years. So it's kind of looking at things from that sort of that angle, and that was very interesting as well. But yeah, it's only as good as you found the data, and I don't think there were some costs associated with it, but those stronger costs are always associated with the healthcare costs.
And we did we did include that definitely in our earlier research planning, and we may have even considered using some of those estimates in our analysis. And then he also did another related study, and probably just around the kind of conversation around the shifting from community to hospital care. I thought I had it here in my notes, but I don't. That's what I was going through the site. But I think it was work that Stephen and Justine did. You're able to estimate that if people have more community contacts in the last 3 months of life, then they're far less likely to die in hospital. Yeah. So kind of demonstrating there the benefits of improving
absolutely
end of life care.
Yeah, absolutely. Yes, and of course, as you say, the left shift to community, we've sussed that now, haven't we? And it's all sorted. So we've been working on that for a few decades now. But we're doing quite a lot again, the strategy unit and the sort of new hospital program as well. We're trying to sort of design new hospital settings, which very much link in with the wider health and care landscape. So we will just basically mend it all, and it'll all be fine. Yes, so I was going to. I mentioned it. We're approaching time. I didn't actually speak to you. I emailed you about my dad previously, and I think it'd be useful to lay on top of some of this work some sort of case studies. Obviously that's not for today, we've got literally 30 seconds, but I think it'd be useful to have those case studies so you can actually unpick the bits that you're counting, and the bits that you can quantify, and the associated like costs and so on, and sort of the patients or people's journeys in and out of sort of maybe a hospital environment, in and out of using sort of their interactions with community care, which bits they've paid for, which bits they haven't, and things like that. I think it'd be sort of help to. I'm not sure there's lots of these which have been done, but certainly from my personal experience, it's like very eye-opening, and you can see where things went wrong, and you can see where things could be better. But what you can't see is how all that information, that sort of really rich information, is actually going to be used by policymakers to actually change anything, or they're just going to sort of keep doing the same thing again and again. But with all of this information that we are providing to policymakers, we hope that it'll be used to have a positive impact and change the way that some things are done, because there's a lot of things that need changing, and I think there's a lot of things that need improving. So we have just tipped over to the 12 o'clock. It's now midday +1. So thank you ever so much again, both of you, for coming along today and sharing that with us. I've really enjoyed the session. It's not a fun topic, but I have very much enjoyed the session, and the recording, as I said before, will be on the website, and if you could maybe share your slides, we'll pop those on too. And go and get your report done, Lisa. I'm worried about you getting that done, so just focus on that, have some lunch, and then focus on that, and and hopefully we'll see you again soon, and I'll see everybody else in a couple of weeks. So thanks very much, everybody.
Thanks very much, Rachel.
Okay, bye-bye.
And we actually probably will have a few projects that we can share.
That'd be fantastic.
Because we've obviously got to close off as much as we possibly can before the end of April, but I've done a cervical cancer project. We're working on a leukemia project. Gayathri's working on an economic evaluation of a digital health technology.
Fantastic.
Some social care research as well that she's been leading, and we're doing a bit of a work with BHF around women's cardiovascular health as well. So
brilliant. They all sound amazing. I'm hugely interested in that. So this means we have to book you in, doesn't it?
Yeah. So when we're close to completing things, I'll send you a note.
Fantastic. Well, I look forward to that. And thank you very much.
Nice to see you. It's nice to see you.